All right, let's break this down. Here we have a coronal CT image of the abdomen, and what immediately draws attention is the abnormal appearance in the right lower quadrant. We can see high attenuation material in the cecum, transverse, and descending colon. Now, this is likely to be residual barium from a prior gastrointestinal contrast study, which is an important detail because it helps to explain some of the dense areas we are seeing. But that's not all. The wall of the terminal ileum is thickened, which is a red flag, and surrounding this area, we see streaky mesenteric fat. This is a classic sign of inflammation. In addition to that, we have some fluid in the area, particularly in the inferior aspect of the abnormal fat, right near the cecal pole. This free fluid further supports an inflammatory process going on in the abdomen. Now, there's another significant finding: enlarged lymph nodes that are tracking along the ileocolic vessels in the mesentery. When we see enlarged lymph nodes like these in the context of bowel inflammation, it adds weight to the idea of a chronic inflammatory condition. One striking feature is the convergence of the distal ileal loops, forming what we call a cloverleaf appearance in the right pelvis. This is classic for a cicatrizing process. Basically, bowel loops becoming adherent due to inflammation over time, leading to adhesions. This appearance, alongside the changes in the terminal ileum, strongly suggests Crohn's disease with complications like an enteroenteric fistula. Now, in terms of differential diagnosis, the main contender is Crohn's disease, which we see here manifesting with thickening of the bowel wall, mesenteric fat stranding, and fistula formation. A history of inflammatory bowel disease, particularly Crohn's, would make this the leading diagnosis. Other conditions that might cause fistulization, like malignancy or other chronic inflammatory diseases, are less likely given the pattern we're seeing. So the next step in managing this case would be to consult with the gastroenterology team. They'll likely want to confirm this diagnosis with endoscopic biopsy of the terminal ileum. Cross-sectional imaging like MRI can be helpful to further delineate the fistula tracts, but endoscopic inspection and biopsy remain key here. Remember to subscribe to Radiology Made Easy if you found this helpful. Leave a comment below and tell me what other topics you'd like to dive into. Let's keep breaking down complex cases into simple, bite-sized knowledge.